Hello everyone, this is Dr. Richa. In this video, we will talk about cardiac glycosides and their uses, mechanism of action, side effects, contraindications, etc. So, digoxin is the only drug in cardiac glycosides which is used these days. What is the mechanism of action of digoxin? Digoxin is basically an inotropic drug, that is, it increases the contractility of heart. So, for remembering the action of digoxin, just remember CCD, where D is the digoxin and one C is for contractility and the other C is for conductivity. So, digoxin increases the contractility of the heart while it decreases the conductivity of the heart. So contractility, that action is by its direct action, while conductivity, it's indirect action. That means it basically stimulates mimics the vagus action. It is vagomimetic. Okay. So what is its action on contractility? So here is this diagram showing plasma membrane of the cardiac muscle cell. Right, this is the T tubule, this is the muscle membrane which has invaginated into T tubule, and here there is association of L tubule with the T tubule. So what is its action? Whenever the cardiac muscle cell is stimulated, the action potential travels via this T tubule, and there is some association between this T tubule and L tubule. And when we are talking about the cardiac muscle cell, during the action potential itself, there is entry of calcium. Okay, so calcium enters into the cardiac muscle cell during the action potential. I mean, when the action potential is generated, there is opening of the voltage gated calcium channels and calcium enters into the myocardial cell. So calcium enters from extracellular source, but also some calcium is released from the intracellular source, that is by calcium induced calcium release, CICR. Calcium causes the opening of the ryanodine receptors which are present on these L tubules, and there is release of calcium. Okay. So this calcium which has entered both during the action potential, that is extracellular source, and from the L tubules, that is the intracellular source, this increased calcium now within the cell will cause the muscle contraction, that is actin-myosin interaction is going to take place. Now, because the calcium level is directly proportional to the force of contraction, that is the fundamental physiology. As the calcium levels will rise, force of contraction is going to rise. Digoxin uses this mechanism for increasing the force of contraction. So what it does, actually on the membrane there are certain transporters are there. This sodium potassium ATPase is there, which is present on all the cells, right? Then there is sodium calcium exchanger, which brings in 3 sodium and throws out 1 calcium, and then there is this green color you see on the L tubules, that is Sarca pump. Okay, smooth endoplasmic reticulum calcium ATPase. Now, the calcium which has increased for the contraction, now it has to be thrown out also, right, for the muscle relaxation. So, it is thrown out by this sodium calcium exchanger, so that calcium moves out of the cell and some of it moves into the L tubules, that is the Sarca. Now, digoxin blocks this sodium potassium ATPase. So, how is it related to calcium? Yes, you see, sodium potassium ATPase main function is throwing out 3 sodium ions and bringing in 2 potassium ions. So if digoxin blocks this, there is no gradient for sodium ions. Okay, so you see this transporter, sodium calcium exchanger, what is it doing is bringing in 3 sodium and throwing out 1 calcium, and this is a counter transporter. That means sodium is moving along its gradient. Okay, one ion moves along the gradient in the counter transport, other ion moves against the concentration gradient. So this sodium potassium ATPase is maintaining the concentration gradient of sodium from outside to inside. Sodium was moving out and same sodium is now entering via this counter transporter, and because of this only, this counter transporter is working and throwing out calcium ion. So if digoxin blocks this sodium potassium ATPase, then the gradient for sodium from outside to inside is not established. Okay, we can say it has decreased. So the functioning of this sodium calcium exchanger decreases. So that means now calcium is accumulating within the cell, and this calcium will move inside the L tubule. So here there will be lot of accumulation of calcium. Okay, that means in the next impulse, the next action potential which will arrive in the muscle, now this extra calcium will be released from this L tubules into the cytoplasm. So this is known as calcium transients. Calcium transients, increase in calcium within the cytoplasm due to the action potential, it is known as calcium transients. It is for very short time and then it decreases. So what we are saying here is that because of blockage of sodium potassium ATPase by this digoxin, now calcium transients which occur due to calcium release from the L tubules, it increases. Basically, in next action potential, the calcium release is increased, so there is more intracellular calcium, and since calcium concentration intracellularly is directly proportional to the force of contraction, so force of contraction increases. Okay. And this effect is mainly seen in failing heart, that is a heart with systolic dysfunction, not diastolic dysfunction. Systolic dysfunction, that means a heart that is not able to pump adequately. Okay, so that is the mechanism of action of digoxin, that is the direct mechanism of action. Now 2-3 things, some facts I will tell. One, digoxin acts on it binds on the alpha subunit of this sodium potassium ATPase. Sodium potassium ATPase has 2 subunits, alpha and beta subunits. Digoxin binds slowly on this alpha subunits, not very fast. Okay. Second, because this calcium accumulation takes time within the circa, the calcium which is accumulating, it takes time. Digoxin is slow to act. Okay, so over time its action builds up. In fact, the T half of digoxin is 36 hours. And the action, it starts in approximately 6 to 7 days. Okay, why? 2 reasons. One, it binds slowly to the sodium potassium ATPase. Second, calcium accumulation within the circa takes time. Okay, 2 reasons. Then third point is that digoxin increases the force of contraction in a dose dependent manner. As the dose increases, force of contraction increases. Okay. Then finally, digoxin does not increase the heart rate. See, it is increasing the heart contraction only, but heart rate is not increasing. So oxygen consumption by the heart, it is not increasing much. Okay, understandings, and that is very important in a failing heart where we don't want oxygen consumption to increase. There might be certain sympathomimetic drugs. There are certain sympathomimetic drugs which increase the heart rate as well, and they increase the oxygen consumption by the heart as well. But in this aspect, digoxin is very good in the sense it increases only contractility and not heart rate. Okay. Now, moving on to its indirect action, that is the action on the action that is vagomimetic. Okay, so by that I told you that it decreases the conductivity. So here I have drawn SA node, AV node action potential. Basically, heart has 2 types of cells, autorhythmic cells and contractile cells, and you see their action potential is different. Okay, so this is SA node, AV node, Purkinje fiber action potential, and this is contractile cell action potential, that is atrial and ventricular action potential. Now, due to its vagomimetic action, what this digitalis does is that it decreases the slope of this action potential. This is known as the pacemaker potential. It decreases the slope of this action potential and also increases this negative value of the RMP. Here it is minus 60 millivolt resting membrane potential, but due to the action of the digoxin, this negative value decreases to much more. This is known as maximum diastolic depolarization. Okay, that means now the cell will take more time. The potential change in the cell is going to take more time from starting from this RMP to reach to the threshold. Plus the slope is also decreased, so it will not go parallel to this. In fact, it will go like this. Okay, so what will happen to the heart rate? See, this action potential generation in the SA node is responsible for the contraction of the heart. It will stimulate the entire heart, and because of that there will be heart contraction. That is basically counted as one beat. So number of impulses which are generated in SA node, that will be equivalent to heart rate, right? So here what we are telling, that because the slope is decreasing and maximum diastolic depolarization is increasing, it is becoming more negative, the number of impulses which are going to be generated in 1 minute, that is going to decrease, right? Number of impulses are going to decrease, so that is also going to decrease the heart rate. So there will be decreased heart rate, right? Here I told you that it doesn't increase heart rate. On the contrary, it is decreasing heart rate, right? Now, AV node also same effect is there, that is decrease in the slope of the prepotential. This is known as prepotential, and increase in the negativity of the RMP, that is maximum diastolic depolarization. So this leads to decrease in the conduction speed. So impulse generation which is happening in the heart, this is SA node. Now it will slowly travel, it will reach to the AV node. Here the pause will be longer, so that is going to decrease the conductivity, right? Now moving on to Purkinje fiber. Purkinje fiber, though it is part of the conduction system, effect is little different. In fact, the direct effect at higher doses it is there, and it increases the automaticity. Okay, it is opposite. So what we are saying is that in Purkinje fiber, same action potential will be there, but the slope of this prepotential, it is going to increase in Purkinje fiber. So if this slope is increasing, what is going to happen? Number of impulses which are being generated in Purkinje fiber, it is going to increase. And I told you when it is happening, it is a direct effect happening on Purkinje fiber. What it is doing, it is increasing automaticity. It is not a vagomimetic effect. Understanding? So SA node, AV node, vagomimetic effect. So one thing you remember here, it increases the automaticity. But at higher doses, it also decreases the conduction in the Purkinje fibers. So try to understand this, that individual Purkinje fibers, automaticity is increasing, impulse generation number is increasing, but the conduction time here in the Purkinje fibers, the cells are connected to each other, that is decreasing, right? So suppose if there is an ectopic impulse generation, automatically this Purkinje fiber generates an impulse, and already the heart is getting depolarized. Due to the impulse generation from SA node to AV node, that is the normal impulse is causing the heart depolarization. Now suddenly there is an ectopic focus, say somewhere here, and it also stimulates the heart. Now what happens, that because of the slow conduction, this impulse is going like this. Okay, this will come, but here also this is stimulating, and now it is slowly coming. So by the time this old impulse, the original impulse, it is there, by the time the impulse from the ectopic focus has reached this particular area, here repolarization has occurred, already repolarization. Understanding? So two important things, automaticity plus decrease in conduction. What happens, that this impulse now can stimulate the original area again. So what is this? This is re-entry of the impulse. Okay, so now it is going to stimulate the ventricles, and this is going to lead to arrhythmia. So this is dangerous. Why it is dangerous? Two things. One, automaticity of the Purkinje fibers, but decrease in the conduction, right? So this is dangerous, right, in Purkinje fibers. So that is opposite, remember, compared to SA node to AV node, increase in automaticity is there. Then what happens to ventricular action potential? Effective refractory period, which is also known as absolute refractory period, that duration is decreased. So if we see the action potential duration, that becomes something like this. Okay, something like this. Duration is decreasing. So that means what we were telling is that this impulse is now able to stimulate the original area. That means, you see, the duration has decreased. That means it has already repolarized. It has become faster. Repolarization has become faster. Conduction here is slower. So one more action is there which is facilitating that now this new impulse can stimulate the ventricles again, because it is sitting there repolarized, ready to be stimulated. Okay, so here I will tell you to watch my video on absolute refractory period in heart, cardiac muscle. I will give the link in the description section so that your fundamentals about this absolute refractory period are clear, right? I will also give the link about arrhythmias so that you also understand the pathophysiology of arrhythmias, where I have talked about this re-entry arrhythmias as well. Okay, so that was about the action on the electrical properties, or the vagomimetic action we have seen, and the direct action also we have seen. Now what we will see in ECG? ECG we see increase in the PR interval because the conductivity is decreasing. We have seen in AV node the conductivity is decreasing. We see a decrease in the QT interval because you see I told you that this action potential duration in the ventricles is decreasing, right? So that is responsible for QT interval. What is QT interval? In QT interval there is ventricular depolarization and ventricular repolarization, so that is finishing fast. Okay, though here it is only single action potential, but when we talk about ECG, it is the entire ventricle we are talking about, whole ventricular depolarization and repolarization. But because single action potential duration is decreasing, so this is also going to decrease. Then there is T-wave inversion. Why T-wave inversion is there? So T-wave inversion occurs. For that we need to understand that how the depolarization and repolarization occurs. Okay, so I'll just rub it here and little bit try to make you understand that why T-wave inversion is occurring. Right. So see, in normal heart what happens? This is the ventricle. Okay, so ventricular depolarization majorly occurs in this direction, right? Ventricular depolarization majorly occurs in this direction, and this direction is in the direction of the lead 2. So here there is positivity, that means the inside of the cell has become positive, that is depolarizing, and here there is negativity inside, that is this part is RMP. So this part of the ventricle gets depolarized first inside positivity. Direction of depolarization majorly is from up to downwards. Okay, and it is taken from positive inside to negative outside. Okay, so it is spreading like this. Now, when the depolarization is completed, what will happen? This will become fully positive. Everything becomes positive. Now no current will flow, and what we get is initially we will get QRS complex. Okay, now when whole ventricle is depolarized we get straight line. Now when ventricle starts repolarizing, actually again this particular area gets repolarized first. So again this is negative inside. Understanding? So again you see direction I told you is from positive inside to negative inside. So again the direction will be like this only during repolarization. Depolarization also direction was like this. Repolarization also direction of the current, it is like this only. Okay, so that is why we get a positive T wave like this. Now, in case of for digoxin, what we are telling that there will be T-wave inversion. Why it is going to happen? That's what I was telling, that because the conduction is slower, everywhere the conduction is slower. So, this area which got depolarized first, now will get repolarized first also. Okay, because it is not yet depolarized the whole ventricle, it is very becoming slower, right? So, this part will get repolarized first, the area which got depolarized first. So the direction will invert because now here this will become negative and the direction will become like this, right? So that is why we get T-wave inversion. Okay, fine. So we have seen the mechanism of action, we have seen the electrical action, what it is doing in the action potential, we have seen the ECG changes. Now let us move on to the uses. What is the use? This digoxin is mainly used in congestive heart failure in which atrial fibrillation is persistent. So in these cases, it is used to control the ventricular rate. Why? See, in CHF, because it is going to increase the cardiac contractility, so it is going to increase the cardiac output. And AF, because of this conductivity, it is decreasing the conductivity. So even if the number of impulse generation in atria is more, the number of impulses which will reach to the ventricles, that is going to decrease because of this decreased conductivity. Okay, so ventricular rate is going to be controlled. So because of its combined action on contractility and conductivity, this digoxin is used in this case. Or it is also used in congestive heart failure which has not responded to ACE inhibitors plus beta blocker therapy. Understanding. So before it was used more commonly, but now because of better drugs available, it is used only if ACE inhibitors and beta blockers combined therapy, the patient is not responding to that. So in that cases also digoxin is used. Okay, so that is the uses. Adverse effects. What will be the adverse effects? Adverse effects happen because of its action, the same mechanism of action which we have seen. Adverse effects happen because of that only. Okay, so what was the mechanism of action? It is blocking sodium potassium ATPase. So we have seen that because of this, intracellular calcium is increasing, right? Basically the calcium within the smooth endoplasmic reticulum, this L tubules, it is increasing. Second, potassium levels intracellular are decreasing. Why? See, when you are blocking sodium potassium ATPase, it is also bringing in potassium. Now this is not going to happen. So potassium is going to accumulate outside, and slowly, because extracellular potassium is increasing, our kidneys are going to excrete this potassium. So extracellular, you will see, okay, potassium levels are fine because ultimately they are excreted, but intracellularly, the cell is depleted with potassium. So there is intracellular potassium depletion. And both of these ultimately lead to arrhythmias. Okay, very important side effect of CHF, arrhythmias. Okay, so if there is toxicity of digoxin, that can be either chronic digoxin toxicity, chronic, or it can be acute. Okay, now because its adverse effects are due to its same mechanism of action, there is no other action, due to the action which is responsible for inotropy, because of this only there are adverse effects. So we say that therapeutic index of digoxin is low. That means the same dose which can cause the effect, same dose can cause the adverse effect. So very narrow range in which it is used. If it increase the dose, then there will be accumulation of digoxin, the adverse effects will precipitate. Okay. Now, in chronic and acute digoxin toxicity, what is this? Acute means the digoxin levels have increased very fast, and that generally leads to arrhythmias. In chronic toxicity, there is slow accumulation of digoxin over time, and this is generally seen in renal failure and also in elderly. Why? Renal failure because digoxin is excreted by the kidneys as such. It is just gets filtered in the glomerulus and it is excreted. So its rate of excretion is similar to that of the glomerular filtration rate. And that is why in renal failure, there is accumulation of the digoxin. Chronic digoxin toxicity can precipitate, and also in the elderly. So we have to be careful with the dose in case of renal failure and elderly. And in this case, the main symptoms which come first is the GI symptoms and also the CNS symptoms. Okay, what is the treatment? In chronic, we have to give potassium infusion. Potassium infusion because we have seen that potassium is low intracellularly, and also in chronic and acute we can give this antibody against digoxin, that is the Digibind. Okay, this is the Fab fragment antibody which can bind with the digoxin and remove the digoxin. In acute, remember however that we cannot give potassium. In chronic we have to give potassium infusion. In acute toxicity we should not give potassium. Why we should not give potassium infusion in acute? See, when acute toxicity has happened, it has blocked sodium potassium ATPase. Lot of potassium is outside. So already potassium levels are high. In chronic, this potassium high levels, during that time the kidney will excrete. So extracellular potassium levels will be normal. But in acute toxicity, this potassium levels extracellularly will be high because this has not gone inside and the kidneys have not been able to excrete it. So we don't give potassium infusion in acute toxicity. Right? Then moving on to the last part, that is the contraindications. When should we not give digoxin? One, in renal failure. I told you that digoxin is excreted by the kidneys as such itself. In case of hypokalemia, we should not give. Why? In hypokalemia, what happens that this digoxin binding to sodium potassium ATPase increases. Okay, so its effects increase, so we should not give. All this it will cause arrhythmias. Thyrotoxicosis, there are increased chances of arrhythmias. WPW syndrome, what is this? In WPW syndrome, there is a tract connecting the atria and the ventricle apart from the conducting pathway. So digoxin decreases the refractory period of that tract. Bypass tract is there. So that means now impulses can pass via the tract also. So it can precipitate arrhythmias. Then partial AV block we should not give because it can precipitate complete AV block. Why? Because it is decreasing the conductivity, right? So partial AV block will convert into complete AV block. And ventricular tachycardia also we should not give. It is contraindicated because it will precipitate ventricular fibrillation. Again, because of its effect on the refractory period, conducting pathway, automaticity, it is increasing the automaticity and decreasing the conduction in the Purkinje fiber, so that now time is available for re-stimulation of the ventricular muscle. Okay. So that was all about digoxin. I hope I was able to clear your concepts. Thanks for watching the video. If you liked it, do press the like button, share the video with others, and don't forget to subscribe to the channel Physiology Open. Thank you.